Good morning, everybody. We're about to start our webinar. It's noon your time, 9 a.m. my time. I apologize that I could not be there in person. My name is Dr. Jasleen Chotwal. I'm the Chief Medical Officer as well as the Director of the Mood Program here at CER Tucson. And I will be presenting on For Whom the Bell Tolls. So we're here today to discuss our objectives, which is to define opioid use disorder, its subtypes, describe associations between early life trauma and opioid use disorder, review the impact of attachment on the reward system and opioid use, and then finally identify some treatment approaches to opioid use disorder. What is an opioid? Opioids are naturally occurring substances that are present in our brain, our body, but are also usually interacting with opioid receptors on nerve cells, both in the body and the brain. Some of the naturally occurring kinds can be just opioids that are intrinsically generated by our brain and our body. And then the other naturally occurring kind can be something like poppy seed. Another form of opioids can be synthetic or semi-synthetic, and these are really the street drugs or prescription drugs, etc., that we also hear about. Some of them are synthetic or semi-synthetic. One of the most synthetic forms that nowadays is causing a lot of problem is fentanyl. And then opiates and opioids are often used interchangeably, but there's a slight difference in these two terms. Opiates, which is OPIATES, usually are the natural opioids, such as heroin, morphine, codeine. These are more so naturally occurring substances in nature that we've been able to harvest and then recreate. Opioids, on the other hand, refers to all types of opioid substances, both the naturally occurring as well as synthetic and semi-synthetic. So the opioids typically act on the reward pathway, and that is really where they have their benefit and why they're important for us. But then also, this is really how we notice that they start causing some problems. So the reward pathway is typically stimulated naturally by all things that we find pleasurable. This can be eating, social interaction, sexual activity. It typically causes dopamine to be released in our brain, and so we always talk about dopamine being the feel-good hormone. So when it comes to these opioid substances that we're talking about, they typically attach to mu opioid receptors on our neurons and hence activate the mesolimbic reward pathway, which activates signals in an area called the ventral tegmental area, which then further releases dopamine in the nucleus accumbens. This system essentially generates these signals such that we can start feeling pleasure. So this will activate naturally when we're doing the activities we mentioned earlier, but then also when I may imbibe an opioid substance, I would also have these similar feelings of pleasure. And this is a graph or an image depicting those various areas. So here where you see it, say VTA, that's the ventral tegmental area. NAC is the nucleus accumbens, which is releasing the dopamine. Other areas that are important in the mesolimbic reward pathway is there's highlighted the PFC, which is called the prefrontal cortex. This is an area that makes us uniquely human and essentially helps us control impulses. So feedback from the prefrontal cortex to the ventral tegmental area actually helps us overcome drives to obtain pleasure all the time. So it keeps us sort of socially responsible. So when it's unsafe or unwise, we're not just going to be, having sex in social places. We're not overeating because we're trying to be also mindful of our health. But this is really the area that starts to have lower feedback. So the prefrontal cortex, we can see, is typically being underactive in individuals who are addicted to drugs. Another area that's marked in this diagram is called the LC, or the locus coeruleus. This is also an area that plays an important role in drug dependence. We won't be going into it in detail right now, but that's just another area that we typically look at when we're thinking about origins of addiction and how it's getting propagated. So looking further at the neurobiological bases of addiction, this is further from the same paper that the prior diagram was from. And this shows what's happening inside a neuron. So you see the neuron cell wall and on the left side image, and this is normal function where you have a converting enzyme sort of sitting in your cell wall, and you have the opioid receptor sticking out of your cell wall. And inside the cell, once that does get activated on the image to the right with an opioid coming in, attaching to the new receptor, it activates the release of dopamine inside the cell after release of the CAMP. So as that is happening, you start noticing that if we start imbibing greater number of opioids, the converting enzyme overall volume increases significantly. And so essentially it's upregulating that mu opioid receptor, where the mu opioid receptor needs more and more opioid all the time, which on a clinical end we see showing up as cravings, or a person not really finding that their pain medication that they were taking for pain control is having as much efficacy as it did before. So this really contributes to why we talk about tolerance and physiological dependence and addiction and all those things happening, is because over time our body just wants more and more, our brain wants more and more of the opioid to feel the same amount of pleasure. This is another figure, again, showing, somebody who's using a heroin injection to get maybe initially relief from psychological or physical pain, and they start to use it. They go from sort of starting out using heroin and getting a bit of a euphoric high to suddenly noticing that the loads become even further beyond their norm. And so when now they're not using heroin or not injecting themselves, they're starting to notice anxiety, dysphoria, and essentially more of like a withdrawal picture. So every time they're going a little bit towards withdrawal, the person is injecting themselves again. Finally, at some point, to break the cycle of drug dependence, maybe they came to see her Tucson, they went to another de-addiction center, stopped using, they might start noticing symptoms of withdrawal as they're initially coming on. And so this is where drug craving will increase. There'll also be typical symptoms of opiate withdrawal that in a medical setting we'd be trying to manage. And then over time, as they're doing therapy and they're engaging in treatment, we start to see that their mood can start changing, and all thanks to neuroplasticity and their brain trying to get back to its old baseline, that they start to be less dysphoric and maybe going towards a more normal mood state. And then lo and behold, they have a life stressor, a loved one dies, a relationship ends. And this is a story we see play out clinically many, many, many times if we're working in the addiction field. And then with that life stressor, suddenly the person's own capability to manage their emotions reduces. And so they again have this dysphoria. And that reminds them, oh, remember last time when I took that heroin injection, it made me feel so much better. And so it's sort of that learned behavioral response to dysphoria, that this may be a time that's very, very high risk for them for relapse, because they're now having cravings, they're feeling a lot of pain. And often we notice for individuals who develop addictive behaviors that tolerating emotional and psychological pain is not really a strong suit unless they've done very intensive treatment. And so again, that just opens them up to relapse, which is what you see on the right-hand corner of the slide. Moving forward, as we're talking about all of these things, I wanted to take a minute to, just revisit, define opioid use disorder. I'm pretty sure anybody who's on this webinar knows what it is. but it's also partly my duty to reiterate that again. So opioid use disorder is a problematic pattern of opioid use leading to problems or distress with at least two of the following occurring in a 12-month period. So what are the two things that need to occur in the 12-month period? So it can be taking larger amounts of the opioid or over a longer period than intended, so essentially just using more than you thought you would. Continuing to have a persistent desire to use, and then also sometimes the person might realize, I don't want to use, but they're having difficulty cutting down. Spending a great deal of time obtaining, using opioids, having cravings, problems fulfilling obligations at work, home, or school, and then further, it can also be that they're having social or interpersonal problems. They're reducing other generally enjoyable activities because of opioid use. They're also continuing to use opioids instead of there being physical issues that, or them putting themselves in risky situations, so going to a dangerous neighborhood to try and obtain, or going after shopping to multiple places where you can be found out. Also continuing to use the opioid substances in spite of physical or psychological problems. So this can be starting to notice that, I'm really getting dependent on this. I'm not being able to function with this. I'm not being able to maintain my mood without this. And then the concept of tolerance. That is another one of the symptoms that we can see in opioid use disorder, which is essentially just needing to use greater amounts. And this is more of a physiological process where, like we had shown in the prior diagram, that is essentially your receptors get upregulated and they just want more to have the same amount of feeling. And then finally, the last one, experiencing withdrawal. Typically for me, I think, if somebody has physiological tolerance and dependence to the substance, they will have withdrawal, but that's really what this is talking about. So this is a person who, when they decide, okay, I'm going to stop now, or I ran out of my supply, they start having withdrawal symptoms. So an individual to get the diagnosis of opioid use disorder really only needs two of these symptoms over the last 12 months after continuing to have a pattern of opioid use. And definitely for it to be a disorder, it has to cause some problems. When we see our patients, they have different levels of insight on what really is a problem or not. I might have their clinician telling me they're having problems, or might have their family member telling me they have problems. But it may be that at that point, their own insight into it is not quite present. So it's not really just about whether your patient thinks they have a problem. It's also up to your clinical judgment in that case. And so there's various subtypes of opioid use disorder. Mild is when there's 2 to 3 of those 11 symptoms. Moderate is 4 to 5 of those 11 symptoms that we had noted. And then severe is 6 or more. And I think if you use ICD, 10 still, mild typically equates to opioid abuse, and moderate, severe both equate to opioid dependence, which are terms that we're getting away from a little bit in the U.S. But still, for billing purposes and other things, we still have to use ICD-10, so just something for your knowledge. And so what is the opioid epidemic? We've obviously noticed these are some strong substances. And so why have we started calling it the opioid epidemic? So the prevalence of opioid abuse or overuse, misuse was named an epidemic by the Obama administration. And the main reason was that we were seeing a great number of drug overdoses in the U.S., and we continue to. So more than 70,000 people died in 2017, which is part of the latest data that we have. And most of them involved either a prescription or an illicit opioid. And often we also noticed that these overdoses were more deadly if there was a second drug being used at the same time. So an opioid and a benzodiazepine, or an opioid and some other kind of antihypertensive agent, And so that's where the more number of drugs somebody uses, the higher likelihood that that can result in death. And just in the time that we'll be talking today, there's close to 15 to 20 people who may die of a drug overdose death. And so that's really a big number because we're only talking for an hour and a half. And we're looking at about 200 people dying every day. And so just in the time that we're talking about the opioid epidemic and what to do about it and what's causing it, we'll be losing a lot of people. And, you know, we're in the middle of the COVID pandemic, which is a problem all its own. And when we think about the numbers of how many people are affected and how many deaths, you can really see what a big issue this opioid use disorder has become, and to the point that it really is an epidemic. And drug overdoses are now the leading cause of accidental deaths in our country. This is a diagram just to show state-based overdose deaths for the state population and such. And this is really an important figure because based on where you are, you can start seeing that this is really a problem everywhere. There's no place that's protected by it, so it doesn't matter what your political affiliation is. It doesn't really matter, you know, what part of the country you call home, whether you're from the East Coast or the West Coast or from the middle. It's really affecting all of us equally. And I think your state, for most of the people on the East Coast who are dialing in my state, we're all in the highest range at this point. This is another message to really push that point home about how this became an epidemic. So back in the 90s, our physicians were prescribing a lot of opioid prescriptions. So this is when people were easily getting months worth of pain reliever medications, which were typically narcotics. There was a lot of misinformation by companies that these were not really addictive drugs. There's a couple other substances of use or abuse that are currently having that perception. So that sort of makes me a little bit wary when we talk about cannabis and other things. And obviously, this is not the platform to discuss that. But back in the 1990s, we thought these were very safe drugs, and we were prescribing these heavily in the medical provider field. And then we started noticing about 10, 20 years down, there was an increase in heroin that we were seeing as part of overdose deaths. And pretty soon after, by about 2013, we started seeing synthetic opioids come into the market, and especially in illegal forms, that at this point, whenever we have patients who struggle with opioid use disorder, we really try to highlight and educate them from more a harm reduction perspective, that no matter if, you know, a drug dealer or if your friend is telling you this is morphine, or they're telling you this is a Percocet pill that they're giving you, there is so much more strong fentanyl-based medications or pills that are out there in the market that you may never really know what somebody's giving you. And the likelihood that you could die from that is very high. So really encouraging people to be on medication-assisted treatment such as buprenorphine or even methadone as a way of knowing exactly what's in their medication. Similar to the three categorizations we just looked at, there's this infographic about the same wave, you know, prescription opioids increasing. Finally, we're starting to see them plateau off. And I think the data from the last couple of years shows that they may be dropping off finally. And then again, massive spike in heroin use in the 2010 and on time. And then again, seeing a little bit of plateauing. But the really dangerous and scary piece right now is these synthetic opioids that we're noticing. Moving on more to what are other things we can do in terms of other ways of looking at the opioid epidemic. Typically, we look at it from somebody having a genetic predisposition to addiction. We think about how strong these opioids are. And so Dr. Bruce Alexander and his colleagues in the 1970s were part of a research lab and doing a lot of studies on opioids. That was also a time that the war on drugs was active, and so a lot of the studies that were coming out, which were behavioral psychology type of studies, where they were using Skinner boxes, they would place rats alone in a cage, offer them 2 water bottles, one with just water, and then the other one which would be laced with heroin or cocaine. And so these experiments were showing that the rats would repeatedly drink from these drug-laced bottles until they either overdosed or they died. And so all it made it really seem was that these drugs were very, very addictive, and no matter what you did, these were going to get you. So the campaigns that were really popular at that time mostly said, just say no. And Dr. Alexander and his colleagues started to question these a little bit. To say, well, if the rat doesn't really have anything else to do in that Skinner box, and that Skinner box looks not really the most fun place, then yeah, they're going to have these drugs and they're going to imbibe them. So they created a new experiment, which was called the rat park experiment, in which they also created for one set of rats the option of socializing, playing, or having sex, and then continue to provide them access to just water and drug-laced bottles. And some of you may already be aware of these experiments, but lo and behold, these rats, some of them were in these cages, which are the solitary confinement type of cages where, they just had the 2 types of water bottles. But then the second set of rats started having this rat park. So you can see some wood shavings. They have some empty cans that were available for them to play in or roll around in. And then they also had other mice to play with, so they could cuddle or chase each other around. And you also see them playing here on this hamster wheel or mouse wheel type of thing. And so in these experiments, they started to notice that the caged rats definitely repetitively drank from the drug-laced bottles. And yes, they continued to overdose and die. But the rats that were free in the rat park actually preferred plain water most of the time. There were still some of them that would consume the drug-laced liquid or water. But even those that went to the drug-laced liquid, they would try it, maybe go back once in a while, more so recreationally use it and not obsessively. And none of them really seemed to overdose. So this caused the community and psychology to sort of step up and say, wow, okay, maybe there's something we're missing. And so there was a thought that maybe social community can beat the power of drugs, like we can just all be together, be in harmony, and then people won't really find drugs as attractive to use. However, there were some shortcomings and critique. So one thing was that the rats were of mixed gender. And so what that did was that they were procreating. And so then another critique was that then there were new pups getting added or new rat babies getting added, if pups is confusing, every so often. And there wasn't really mention in the rat park experiment publications about how that was going to be addressed in terms of the scientific validity of these studies. So this was back again, like I said, in the 1970s to 80s. And then we sort of put these away a little bit, saying, well, yeah, they're meaningful, but they weren't really as good as them. And so I came across this article in Neuroscience and Biobehavioral Reviews, where they actually went back and did a review of social environments and social interactions in the development of addictive behaviors in rodent studies. And so they looked at a lot of other studies which seem to look at social isolation, environmental enrichment, which is really what that rat park was. So that was a way of environment for enriching the environment. And then social housing, which was how these rats are mixed up. So if there's 6 drug-using rats that they're used to doing that, then does it really make a difference if they're housed with other drug-using rats or if they're housed with naive or drug-naive rats? So this review article was very interesting to me. The first piece that they broke down was whether the rat was isolated or was in a social setting. So from the review of the literature that they pulled, it seemed that social isolation really did make the rat more likely to self-administer the drug, just like we had seen in the pre-rat park experiments. And that actually, as they were in a more social environment, the self-administration here seemed to reduce the arrows fading off. And then when they're in a social environment, they seem to be more socially dependent on each other and seem to get more reward from that social environment and having some play and interaction with each other. So like overall, there was a reduction in the opioid system sensitivity related to social isolation, in which they just seemed to need a lot more of the drug, whereas if they were socially together, then the opioid system functioned more like its normal self, and then they didn't really need to continue to imbibe extrinsic substance to feel good. The second piece was the standard housing versus enriched housing. So standard housing is, just in a regular box type environment without much opportunity for extrinsic type of play like the hamster wheels or other fidget type of things that rats must enjoy. And then also not really having food available. We looked at the effects of enrichment. It was noticed that the freezing based on where they were. So if they were in standard housing, they found heroin more rewarding. So again, we're more prone to want the opioid. If they were in the enriched housing, then they seemed to get that pleasure and joy from other things. And so again, didn't really need that same self-administration behavior. And then finally, who really are their friends? So they had the effects of social housing conditions. So they had rats that were only given saline water before. They'd never really tried morphine or any other opioid. And then on the far other end, there were ones that had only been imbibing morphine. And so it was noticed that the only difference in these experiments was the peer group with which they interacted. One, they only had other morphine-using rats. One had saline-using, they're all drug naive. And then when you drop them in the middle and mix them up, we noticed that many opioid-related effects, including tolerance, withdrawal sensitivity, and severity of opioid-induced hyperalgesia was started to be reduced in these morphine, the gray rats, which previously were really dependent on morphine, when they were mixed with more naive rats. So it almost makes it seem like maybe the naive rats had something that was different about their neurobiology and their demeanor that helped actually bring the morphine rats more in the middle. And so really that sort of starts talking about, our social mixing too, as much as we can. Typically take experiments from animals and just convert them to human beings. But it starts to look at when we're talking to our patients about what their social behaviors will be after they leave treatment, or do they have really friends who are not drug users, and how that would work out for them. And so here we go, kind of summarizing it overall. So in isolation, we realize that there is increased opioid consumption if a rat is isolated. Enriched environments reduce the overall rewards that they feel with heroin, so you don't keep on going back, and hence you could presume that they would start having reduced opioid consumption. And then finally, if they are interacted with drug-naive animals, then their abuse behavior and abuse potential starts reducing. So having that varied background rats really seem to be helpful in that. In this study, there were also some critiques, and they mostly seem to have utilized male rats out of all the studies that were reviewed for this review article. And so there was this underutilization of females, and that seems to be a recurrent theme in most of the opioid addiction rat models or rodent models. And so I think it's one of those things that puts us in a little bit of a challenging place, because we do know that women or female patients tend to have slightly different reactions and have slightly different reasons that their risk is higher. And so we'll discuss that a little bit later in the presentation as well. So another study that I came across that I, again, feel, takes us in a slightly different direction than just this is happening in my brains, this is my genetics. These are things that are happening in our brains, because essentially anything that you do in your life changes your brain. You sitting here and spending your time with us this morning is changing your brain in one way or the other. And so this study was about adverse childhood experience effects on opioid use initiation, injection, drug use, and overdose amongst human beings with opioid use disorder. And this was really interesting to me because there is some, hypotheses and some research about how ACEs or adverse childhood experiences affect drug use, and we know that it increases risk. But these are very specific things related to opioid use disorders, and I thought would be interesting for us to discuss today. So just a quick review of adverse childhood experiences. So this is also called the ACEs studies. It was done out of Kaiser in California in combination with the CDC. They found that, in the initial studies even, and then there's been broader ACE assessments throughout the country, that most people in the U.S. have at least one adverse childhood experience. And typically that if somebody has 4 or more ACEs, they are at much greater risk of adult onset problems such as heart disease, cancer, diabetes, also addiction, depression, etc. And so if you think about it, looking at this pyramid, there's sort of a generational historical trauma that we now know is even transmitted genetically and then transmitted in our families with more of a social context. Then it's the social condition where you were born, and then finally adverse childhood experiences. So this is while your brain is still growing, where the children's brain is still growing, that it can cause disruptions in your development, and then further difficulties with emotion regulation, etc., higher risk behavior, and then finally lead to greater disease and even early death. We noticed that people with really high ACEs can die up to as many as a couple of decades earlier than the normal population. Types of ACEs, specifically when we think about ACEs now, there's a lot different types of forms, but we usually think of at least 10 primary things. And so they're categorized into abuse, household challenges, and neglect. So neglect is emotional, physical. Household challenges can be, domestic violence in the home. It's primarily taught by the mother being treated violently. Substance abuse, so a parent or somebody else in the house with drug or alcohol use. Mental illness in a family member, especially your caregivers. Separation or divorce of parents. And then a household member could be sibling, could be your parent who is incarcerated. And then also abuse, which is emotional, physical, and sexual abuse. And typically these, when we think about ACEs, these are assessed prior to the age of 18, and we sort of start to measure how many ACEs people have and, what really their lifetime risk of physical as well as mental health challenges will be in the future. How common are ACEs? Well, they're pretty common. Only about a third of people have zero ACEs. A fourth of people tend to have at least one. And then where we get to about 4 or more, which we consider is really that high risk, about an eighth of the population. So that is quite a lot of people. It's, not a quarter, but 1/8. So in any given setting, if we were to know, even 100 people in a setting, about 12 to 13 of them would have that highest level of ACEs that we think about, which is 4 or more, at which we can start to see all the comorbidities come true. So the questions, like we said, physical sexual abuse, neglect, family member with specific types of things, witnessing a mother being abused, that's getting a little bit more generalized to domestic violence now, but those are really questions still. So what is the impact of traumatic stress? Typically, we notice that patients who've had adverse childhood experiences, which we would consider traumatic stress, have difficulty coping, have difficulty trusting in relationships or benefiting from relationships even when those are available. They have difficulty with cognitive processes, difficulty regulating behavior, controlling the expression of emotions. So this can show up as freeze with very little to no emotion, but then it can also show up as fight or flight, where the person goes from 0 to 60 in no time. And then also it seems to affect physiologic homeostasis. So these are people who can have immune system dysfunction, they can have difficulty sort of managing their heart rate, their blood pressure, and then also just nervous system dysregulation, which we notice, which again shows up kind of like that fight flight, which has a physiological basis for it too. Along with early childhood adversity, we notice it has a lot of different and pretty high risk impacts. Increases risk for injury, increased risk for mental health disorders, difficulty with maternal health, also chronic diseases, and then high risk behaviors, which is essentially what we're talking about today, which is alcohol, drug use, unsafe sex. So various things that are considered addictive in its own way. And then also reduced opportunity in life. So not only is it that you're getting beat down by physical and emotional consequences of the adverse childhood experiences, but typically you're also having less opportunity for upward mobility and growth, which is really, what is the American dream, and it's being kept from these individuals. So why is this important again? Like we said, there's the impaired neurodevelopment, impaired immune system responses, high risk behaviors. And so research shows that with appropriate supports and intervention, some of these things can be undone. But this is really puts an uphill climb for the person who's on the other side. And we know that unaddressed trauma can really increase the risk of physical conditions continuing to worsen, and then substance use disorders also continuing to worsen, or a person not really feeling like they're being able to successfully get to the other side. The ACE studies have continued, and they continue to give us some valuable information. And so I think, continuing to look at that role of trauma in opioid use disorder, from which we took this little side tour for the ACEs. So this is, again, that study that I was saying I found really interesting, that was studying the effects of ACEs on specifically opioid initiation. So what age did the person start the use of opioids? Did they have injection drug use or not? And then what was the risk of them having an overdose? So this study was conducted between May and December of 2015. The subjects who were taken were English-speaking adults who had come in for inpatient opioid detoxification. I want to say this was done in Massachusetts, the study. About 530 people met eligibility criteria for the study, but only about 457 actually completed the entire process in the interview. I think some of them did not want to do the study, and then a few were lost to follow-up because they got discharged before the entire assessment could be completed from this detox setting. And they had a face-to-face 15-minute structured standardized interview. And this was done after completion of withdrawal within that first 24 hours of admission. And so the overall demographic, the average age was about 32 years, 71% of them were male, some Hispanic, predominantly white, about 5% Black, and then some people of other who identify as having other race or ethnicity. When they looked at the age of opioid initiation, and they looked at in the last month if they've had any IV drug use. And the other question that was asked was, since your first drug use, so since that point of opioid initiation, have you ever overdosed? So lifetime essential risk of overdose. And then they did an ACE questionnaire, which was the 10-point questionnaire, same questions that we just saw. And so one result was that typically patients who had a high ACE score, the higher the ACE score, the lower the age of opioid. So that was inversely correlated. They also found that for every 1 point increase in the ACE score, so going from 3 to 4, there was a greater than 1 point increase or 1 factor increase in the expected likelihood of IV drug use, as well as greater than a factor increase in the risk of them reporting an overdose. The most commonly expressed ACE question that people said yes to was that they had parents who were separated or divorced. It was almost 60% of the people who said that. And then the other ACE that was pretty high for this group of people was living with a problem drinker or somebody who used drugs, which was over 50%, so I think it was 52-ish%. And then the third highest was having an adult who often swore at them or humiliated them, which was that emotional abuse element, which was 47.5%. And then they also noticed that ACEs were higher than the 5 mils. As as we summarize, it seems like higher the ACE, earlier we're starting to see people use opiates, higher the likelihood that they're going to have IV drug use, and higher the likelihood or the odds that they're going to have a lifetime overdose. Another study that also looked at some associations between childhood maltreatment, which is essentially what is assessed by the ACEs, PTSD. Some of us here at Pure Tucson don't like to call it PTSD. We do for, again, billing, coding, communication purposes, but we think of it more as a post-traumatic stress response, because often, again, disorder indicates that something went wrong, but typically we know that, if you're exposed to some traumatic event, that's really your body and your brain reacting the way they can to keep you safe in that moment. It's also associated in this paper with substance-related problems, which I'll define in a minute. So, I guess my slides didn't work as well as I wanted right there. So there's a lot of words in front of you, but looking at this study, we looked at people who use opioids often report pretty intensive histories of childhood maltreatment, like we saw in the last study. And we also already know at the outset of this study that the severity of maltreatment, or the higher the ACEs are, is correlated with increased severity of substance use. That's what we saw in the last study. And then also substance abuse or substance use related problems. And so these problems can be having guilt and shame, not really being able to maintain your physical health in a good way. And so I think when I was looking at this study, I thought it was really interesting because they're looking at these individuals who have a history of opioid use, who have either misused prescription opioids or used heroin for greater than a year. And so I wanted to try and look through this paper, how the intermediary factors that influence whether maltreatment affects an individual or does not, because we all know people who've been victimized as children, or we've seen patients of ours. We may be those people, and we may know our friends or our colleagues who have potentially many ACEs and have been victimized or had severe maltreatment as children, but it does not really affect them negatively. So this study was looking at what is really that intervening factor, intermediary factor that determines, okay, you have this maltreatment, now are you going to develop opioid use disorder and then substance-related problems or not? Well, they did many, many measures. They really spent a lot of time with their patients. They did a childhood trauma questionnaire, which is a 28-item self-report scale. It assesses the negative childhood experiences, essentially similar to the ACEs. Then the short inventory of problems revised scale. It's a 17-item measure of negative consequences of drug use or drinking. Addiction Severity Index Light, or ASI Light. It's sort of a semi-structured, or it's a structured interview that assesses severity of somebody's drug or alcohol use. Then the short form of the UPPSP impulsive behavior scale, essentially is a questionnaire developed to assess impulsivity, and it's the shorter version, so it was easier to do in the setting. And then finally, there's the PCL-5, or the PTSD checklist for DSM-5, and then a structured clinical interview for DSM-5 disorders, and then a neuropsychiatric interview that was still the DSM-4 version at that point. And so exclusion criteria for this study were active psychoses, or if the person was not English speaking. So they only had English speaking participants in the study. And they were also included if they had any other substances. So it wasn't just opioids, it was plus other substances. They were still included in the study. And so what the results of the study, after they synthesized the data, and they had to try to work it many different ways to try and see where they got a signal. And it was noticed that out of all the various assessments that were done, there were emotional abuse and negative urgency that were most correlated with there being PTSD symptoms and then there being an increase in substance-related problems. So emotional abuse, we all understand what emotional abuse means. Negative urgency essentially means rash behaviors or rash actions when somebody is in a negative affect. So I get really annoyed, irritated with somebody, and sort of the impulsivity that comes from that. There was another measure called positive urgency, and positive urgency essentially meant that it was when somebody was really excited about something or has positive affect, if they were to be impulsive or not. And that was a little bit sub-threshold, though still potentially maybe clinically significant. But really, these were people who were having a hard time with impulse control. This is in line with some other studies that have been done looking at drug use and behavioral, looking at trauma and what really underlies maltreatment and specific outcomes. where I think there was a study on sexual abuse showing that individuals who had had sexual abuse tend to have more specifically sexually acting out behaviors or sexually promiscuous type behaviors increase. So in this case, that same differential effects model held true, that people who had had emotional abuse were more likely to have this PTSD, and they were also tend to be correlated with having impulsive actions. And so we know that emotional abuse typically can limit a person's ability to regulate emotions, and then avoidance in the form of using something like opiates is often, again, a way that people may use or self-medicate, which is a term that's often used in clinical settings to protect themselves from these strong emotions. So looking at the last little bit that we were going to be talking about regarding attachment theory and how that plays into opioid use disorder. Brief overview, attachment theory was put forth by John Bowlby in the 1960s. It continued to be further elaborated on by Ainsworth and others. And initially when Bowlby put out the attachment theory, he talked about the human propensity to seek and develop affectional bonds to particular people. So there was a normal human tendency to really need affection, be affectionate with others. And then he defined what was called the attachment behavioral system, which was sort of a psychological internal system that really motivated us to seek support from others when we were in need. And some of these studies were further extended by Hazan and Shaver in the 1990s. And so then they included attachment in adults as well as in work relationships. And there's some interesting literature on that. Attachment theory in general says that, people are shaped by their prior caregiving experiences or their experience with their caregivers. So how my mom or my dad, who were taking care of me as a child, treated me really influences my general perceptions, emotions, behaviors towards other people. He defined, and then they kind of continue to be defined. Initially, there were 3 attachment styles, but now we consider 4 essential attachment styles. There's the secure, and then there's insecure, which includes avoidant, anxious, disorganized. And attachment styles are essentially cognitive, affective representations of how I see myself and how I see others in relation to me. So it's really a dyadic type of model. And certain attachment-related stimuli in the moment can actually activate mental representations of attachment states. So I may typically have a secure attachment, but if I were to go through a breakup, I may appear not like myself and not as much of a secure person because there may have been a prior breakup that this may remind me of, and I may activate a different attachment state. This can also happen in a positive way where somebody with a more avoidant or anxious attachment in the beginning, if they were to find a more stable partner and be able to meet each other's needs in a mindful way, then they could also start to appear more secure. So it is, really something that can be changed, and something as simple as recalling a supportive relationship can help change that mental representation and bring the person to a more secure place. Just a little infographic. Secure seems to be the largest part of the population. Sometimes we may not feel that way because when we're doing psychotherapeutic work or working with other our patients and such, we may see it a little bit differently. And so insecure, anxious, insecure, avoidant, disorganized. Disorganized is typically the smallest part of the population. But again, we'll see another study in a few minutes that will show us why that's a really important one to keep in mind when we're thinking about trauma, and really looking to change the process, because at least with insecure, anxious, and insecure avoidant, we know what to expect. And so if I knew that either my significant other or a friend had a bit of an anxious attachment, I could adjust to that. But with the disorganized attachment style, that can be a little bit harder to do. So this is I think this is the last study we'll be going through. I'm noticing some little issue with my slide set, but I'm trying to work through it. Let's see. If one of you can send me a message if you're seeing this, that would be great. Okay. So this is going to be essentially the last study that we'll be looking at, as I was saying. I apologize again for some of our technological issues. I think our overall network is being a little bit challenged by this. So we're going to look at these adverse childhood experiences questionnaire and adult attachment interview paper, which really was looking at implications for parent-child relationships, but looking at some of the data that there is around how ACEs really influence drug use. This interaction between ACEs and adult attachment is really fascinating to see how that might actually play into drug use later on. So in this study, they were looking at the association between ACEs and emotional support indicators, as well as adult attachment interview classifications. So the individuals who were in the study, they obviously did their ACE questionnaire. They also were asked about what type of emotional support they typically have. And then they also got an adult attachment interview, which helped to sort of start distinguishing what their typical adult attachment style was. And there were two main types that seemed to be really interesting. When in the adult attachment interview, there would be sort of this probing around early loss or abuse. They were able to elicit responses from people about how they had not really adjusted to these early adversities. So there were individuals who had difficulty with reality testing, being sort of reasonable about their approach to that abuse or trauma that they may have been through. And so we noticed that some people got marked as there being unresolved trauma responses, and then another subset got classified as people who could not be classified into a specific state. So we couldn't really identify what exactly their attachment style was. And so these two were people, so I think sometimes that cannot classify seem to associate a little bit like the disorganized attachment, like they would have very different states of mind. But what they noticed was that both these responses seemed to come in patients who had complex trauma and typically had the greatest number of ACEs. So their ACE scores were typically much higher than the usual. And so looking at that, so there were these ACE assessments. They got scored 1 to 10, split into 5 groups, 0, 1, 2, 3, 4 or more. And then the second set of assessment, which was that adult attachment interview, these were categorized as secure, insecure, dismissive, insecure, preoccupied, or anxious, unresolved, which is, they just did not have resolved experiences. So these were often people who blamed themselves for the trauma occurring to them. They also seemed to have greater degree of self-blame, shame, guilt associated with the trauma, often feeling like they somehow brought it upon themselves. And then there was the cannot classify category, which didn't really fall cleanly into any of the others. And so what they noticed was that in the clinical interviews, both the unresolved and the cannot classify categories seem to have patterns of dissociation, also rapid shifts in their emotional state, also noted to report a lot more numbing of affect, or sometimes even passivity in the experience and not really being fully involved. And so as they broke them down per their levels of exposure to ACE, so as the exposure to ACE seems to increase, so was the likelihood of them being more that unresolved or cannot classify categories. You see, if somebody has 0 ACEs, only about 13% of them fell into that category, but if they had 4 or more, then 65% of those people were judged to be in that in the cannot classify category. And then the second breakdown of data that they did was asking them about emotionally supportive experiences. So people who reported that they had very high, often or very often felt supported in their lives. So that's this group with 7 to 9 highly supportive experiences. They actually had much lower rates at undifferentiated or cannot classify attachment style. And if they had okay, again, we're just having a little bit, okay, and we're back. And so again, their levels of emotional support, if they were low, then they were going to have a greater degree of that disorganized appearing or could not be classified per their attachment style. And this was really meaningful because they actually did this in adults who now themselves were going to be parents. So one of the things that we can notice with that is that if there's a high percentage of people who have insecure attachment styles themselves, and maybe more than even insecure, sorry, disorganized or could not really be classified. And they have a high burden of ACEs themselves, and they're themselves dysregulated, don't really know themselves. They're the opposite of what we want parents to be. They're not really mindful, fully present for their children. Then the likelihood of them continuing to, I think, pass on that trauma and make it a little bit more generational is much higher. And so I think that's where this piece about supportive experiences, really balancing that out, is encouraging. Because now it's not just that, oh, well, this happened to you a long time ago and now we can't really do anything. It does seem that there may be some value in being able to change our social environment in a way that even if a child comes from a chaotic type of home environment, other people or a supportive community environment may be able to change their attachment styles. So where do we go from here? We've spoken about opioid use disorder, why it's such a huge problem. We've spoken in between and many times over about adverse childhood experiences or childhood maltreatment, early life adversity, which all would classify as traumatic experiences. Again, not to discount adult trauma, which I think also can have really huge impact. However, we know that, with that neural development changing in young children, that's really a problematic piece. And then finally discussing attachment and how attachment styles really are based on what type of childhood you had. And so again, that really ties right back into that trauma piece for us. So moving towards solutions, I feel like there needs to be just like this formula for how you get to having opioid use disorder that's treatment resistant, difficult to address. that there is the need for comprehensive interventions that address not just that substance use, but also post-traumatic stress symptoms or trauma, and then help increase emotion regulation. So the three steps that I think would be really important are actual treatment for opioid use disorder, which there's a lot of nice guidelines out there. Trauma treatment, which is becoming more popular, but it's still a bit of a panacea trying to get really good trauma treatment for people that's comprehensive and takes the whole person into account and is not reductionistic. And then finally, prevention strategies, because no matter how much we try to throw time, money, resources at the problem, this is really a problem that needs to be nipped truly in the bud when children are still developing and growing. The treatment of opioid use disorder, this is the simpler one. Withdrawal management, detoxification, opioid agonist therapy, also MAT or medication-assisted therapy. And then these are absolutely incomplete without psychosocial interventions, which would include motivational interviewing. Why are you trying to quit? Why is it important to maintain sobriety? Continuing long-term monitoring, providing really good primary care, because we do know that people who have opioid use disorder might now have a degree of hyperalgesia, because of which they're going to be physically uncomfortable. There's also a lot of sequelae of substance use that need to be treated and to help the person maintain their health. If I had it my way, it would be integrated primary care, but I don't get to choose that. And then finally, referrals for continued psychosocial intervention, whether that's to counselors or support groups, and essentially all of those, because there has been recent guidance that as much as peer support groups are invaluable, those are not sufficient without actual professional guidance. And so this is a nice little algorithm for opioid use disorder for anybody who wants to use it. And so it talks not just about, you getting diagnosed initially with opioid use disorder, and then whether you need agonist treatment or not. There's very few people for whom agonist treatment is not indicated. But in case, that is the case, or sadly for my cohort as physicians, there's a lot of the physician monitoring programs that don't allow agonists, which is hopefully will change at some point, or if somebody really just has significant physical complications from the use. And then finally, if you are using agonist treatment, there's buprenorphine naloxone combination, there can be methadone, there can be buprenorphine alone, not usually recommended as first line for most, but used in certain cases. And then finally, harm reduction approaches, which we'll talk about again a little bit, but this is core treatment of opioid use disorder. Trauma treatment. So there's a lot of good trauma therapies out in the world, but they're all incomplete without there being a trauma-informed approach to the patient. So this would mean detailed history and assessment, safety assessment, really taking the patient's history and their perspective and their context into account. Medication management, which SSRIs usually are first line, and then trauma-focused therapies. Trauma-focused therapies are really the core of the treatment. So CPT has very good data. Trauma-focused CBT has some decent data. Prolonged exposure has been around for a while and is also a gold standard treatment, especially in more combat-related and such PTSD. Then EMDR has a lot of good data regarding its efficacy. I think last year or so, I even gave a presentation which showed that if you added some of these trauma therapies to treatment of depression, it improves the outcomes. And then somatic experiencing, narrative exposure therapy, these are all studies, or these are all types of somatic experiencing and NET that are still gathering its data. They're slightly harder to gather data or haven't been published yet. And then really going on to prevention strategies, which is something we don't often think about when it comes to us as clinicians, because we're busy treating our own patients. But for us as physicians, it's become really important to start being more mindful about prescribing. There have been prescription drug monitoring programs, which were now mandated in all states, or at least most, if not all. There's state prescription laws. In our state, we are only allowed to prescribe 5 days for an opioid naive patient. Educating all doctors, I think we're required to get 3 hours of CME every year around opioids. Then also patient education, because again, it's the patient who really needs to know and understand their treatment, even from that trauma-informed approach. So teaching them safe storage, disposal of opioids, awareness resources about the risks, costs to them. There is an opioid prevention program that has been started for young children and I guess adolescents, which is called Operation Prevention. It's been disseminated to quite a few schools and similar settings where young people may be. And this is really, again, trying to prevent opioid misuse in school children, because we were noticing that even young children may get into their parents' cabinets or such, or there are people trying to sell to high school children and getting them hooked that early to where we know that it affects their neurobiology. Other prevention strategies that have been brought on by our federal government has been safe disposal of medications, prescription take-back days in which they gather tons of medication back, which can be opioids, non-narcotics, etc., just really trying to get these toxic substances out of our homes. And then naloxone use. That is one simple, easy thing to do. So here at Tucson, we now actually prescribe naloxone for every single patient, whether they have opioid use disorder or not, just as a way of it being available in an emergency, because if somebody goes down, that's really one of the things that can be so life-saving to do. And then going to one of those harm reduction strategies, which in some ways naloxone uses also, but needle exchanges where people are using IV drugs, at least we're reducing the prevalence of hepatitis and other bloodborne conditions, HIV. This is just an infographic on the safe disposal of prescription medications. About a third of medications go unused, should not really be thrown out, should not be dumped in our sewers, etc. So now looking at prevention strategies specifically around that trauma or ACEs. So public health measures meant to lower ACEs would be intrinsic to improving opioid use disorder, because we saw in all those studies, if you have a higher propensity or higher early exposure to trauma, you're just going to be neurobiologically set up for more severe addiction. Also improving resilience and connection, so programs such as Big Brothers, Big Sisters, I always get that wrong, but something like that where there is some connection with people, it's improving that positive, safe relationship type of experience that we were talking about as part of the attachment study, and then interrupting the cycle of maltreatment. Again, by trying to identify symptoms, so maybe in pediatric clinics or even in OB/GYN clinics, doing ACE questionnaires to see who are parents who may need the most support. There's even broader social goals like strengthening economic support to families, changing social norms such that there's more positive parenting and good information about that parenting classes. I personally would really like to see in the U.S. at some point there being paid parental leave, because I think those initial 6 to 12 months are so crucial for child development. And just to pinch a few pennies on that side, we're putting our children through ACEs. Parents have no real time to parent sometimes. And so most people are doing the best that they can, but we could really give them the opportunity to make it so much better. Good quality education, healthy child development by having family and parenting classes, and then essentially all the other things that reduce risk. This is another nice infographic which sort of shares the same thing. I just figured, different people look at things a little bit differently. This also talked about an earned income tax credit, which said that some municipalities have implemented that workers who have children get a little bit of an income tax credit, such that they can kind of be above the poverty line and have a better socioeconomic standing, such that child abuse and neglect is reduced. Because as we know, if a parent is working numerous jobs, there's really no time to do decent and grounded parenting sometimes. These are same things, just put in slightly different things. I'm going to skip through those. Actually, teaching skills. This is the part that we were talking about in terms of, building resilience and such. So connecting youth to caring adults and actively so mentoring programs, after school programs, intervening early to reduce harm, so improving primary care services, having victim-centered, trauma-informed services, treatment to lessen the impact of ACEs, so if they could get kind of earlier emotional regulation, etc. training, or if there was problem behavior, it could be addressed early. Our governor in Arizona recently just passed their mental health omnibus, part of which there will be school-based services for for children from all kinds of backgrounds, not just our Medicaid population, which was the case before, but even private insurers will be required to fund counseling services at school, so that children, instead of being punished and put in detention, can be identified early for behaviors and be screened, and they're them starting to get some support so as to lower this impact later on. I'm going to end here. Thank you so much for your attention. And I go back to Ernest Hemingway, who helped me get the topic for this presentation. I really think these community interventions, as big and daunting as they may seem, they're really the key for us to impact the opioid epidemic, because really nothing else has. And for what are we born if not to aid one another in getting to a better place and staying healthy? And I also want to thank you all for aiding me and not being able to travel, and you joining me remotely like this in spite of some of our little glitches. I'm going to try and see if there's any questions that have come through. Somebody had kindly tried to tell me they couldn't hear the audio. I'm hoping, Aurelis, that you got the audio later. If there's any questions, you can go to the little screen on the right and type them in, and I'll wait and see if any questions show up on my screen. I'm also learning this program right now. And I hope we'll, thinking about opioid use disorder, not just as a substance use disorder, but thinking about it holistically as to why this person needed to use that strategy to take care of themselves, and really addressing that underlying trauma and difficulties with attachment would be very important. We can make the PowerPoint slides available to all the registrants who had signed up. I'll have Courtney, who's our marketing guru, maybe try and send those out to you after this. I don't know if that you can get it right off this platform, since it was making me screen share. And I think Courtney is also the one who will be working on getting you your CEs. So I'm hoping those are useful for you while you took your precious time to be with us. I got a very kind comment from somebody, but I'm not seeing any other questions. So I'll wait another couple minutes. So one of the questions is about the study that showed the attachment, which was the adult attachment interview. And so the question was really asking how we look at these patients who have that undifferentiated or the cannot classify type of response. And so the way the researchers in that study determined that was that the adult attachment interview is an actual interview in which they conduct questions and ask about the history of trauma and the person's overall lifetime development. And when they hear those terms such as terms which are questioning, why did they get traumatized? Maybe I'm wrong. Maybe there was something wrong about me, the one to blame. Those were the statements that predicted for them that this person still had unresolved trauma. So those were really the hallmarks of the unresolved trauma for them, for the U. And the cannot classify was more just non-specific type of responses where none of the responses seem to be in a pattern. So that would really be somebody who comes across as pretty disorganized. In different settings, they're answering your same question in different ways. So that's really the one that stands out a little bit differently. But both sets of people who have the unresolved responses, unresolved trauma responses, as well as the cannot classify, typically seem to have things that we would consider pretty typically as trauma responses, such as dissociation, rapid shifts in emotional state, numbing, etc. So that is really the answer to that. If you have any questions, feel free to email me. This is my email address. It's my first name dot last name at sierratucson.com. I'm also happy to have a phone conversation with anybody because I was really hoping to see most of you in person. I hope you'll maintain good health and social distancing and hand hygiene and take care of your health, and hope to see you next year, if not sooner. Thank you again for your time today. I'll be trying to disconnect it from my end. So once again, thank you.